Over half of American men over the age of 40 suffer from erectile dysfunction and other sexual disorders. Unfortunately, most men find these kinds of problems too embarrassing to talk about and never do anything about it. And as you can imagine, male sexual dysfunction is a major cause of poor quality of life in men. And not only that, it can actually be an early indicator of more serious health problems such as diabetes and cardiovascular disease. The point is that the issue is way too important for both quality of life and health span to ignore any longer. My guest this week on Sapio with Buck Joffrey is Dr. Justin Howman of Tower Urology at Cedars-Sinai Hospital in Los Angeles. Now, Justin is a urologist and fellowship-trained male reproductive medicine and surgery specialist focused on men's health, including male hormone management, erectile dysfunction, male fertility, and Peyronie's disease. This discussion was really interesting, and I guarantee you that it's relevant to either you or to someone you know, so make sure to tune in. And as always, if you like what I'm doing, make sure to like, share, and subscribe to the show.
In pursuit of health and wisdom, Sapio with Buck Joffrey.
Hey, Justin.
Hey.
How you doing? Thanks for joining me today. So, how you doing?
Good. Good. Excited to do this. Thanks for having me.
Good. So we're I'm pretty excited to have you on here because I didn't realize like how big of a problem that erectile dysfunction and men's sexual health issues were until I started diving into this stuff. So let's just get started. Let's start with this concept of erectile dysfunction, just so we can set the stage in terms of the rest of the show. What exactly is, like, how do you define erectile dysfunction? I mean, it's not just like, one night you drank too much, had trouble, and the next thing you had a problem and now you've got erectile dysfunction. It's not quite that, right? I mean, specific definition on that.
Yeah. So, I mean, it's good to start with a good definition, but the idea really is it's the inability to either attain or maintain erection for satisfying intercourse. So, usually guys are able to attain the erection, get the erection, but they have a difficulty maintaining it. But that's really what it comes down to. Those difficulty with either one of those two.
Now, do you define it as like if somebody has it, how many times per month, always versus sometimes, that kind of thing, or is that?
Yeah, that's the part where it's a little bit more gray. But if let's say you 1 out of every 10 times you're experiencing that, then you've had one episode of erectile dysfunction.
Right.
So that's the idea.
Right. So you have to determine sort of the severity, and that's where the clinical element of this comes in.
And how much it's impacting your sex life. And
right.
If it's impacting you, then you talk to somebody about it.
So here's the numbers that I think are pretty incredible. 52% of men over the age of 40 suffer from some level of erectile dysfunction. That means 30 million people. That's huge.
That's huge. It's a massive number.
Right.
Massive number. And a lot of them live in shame.
Yeah.
There's a huge taboo.
Yeah, absolutely. And so when you think about these people who come to your office, I mean, they're just like everybody, right? It's not like you've got people who are just unhealthy or obese. I mean, describe this patient population in general.
Yeah, so it's really all men from all walks of life, more so now than I would say ever before. I mean, it's a couple of things. Number one, a lot of these online, medications that we're
that's right.
What they've done is they've kind of normalized the conversation in some ways. So people who were living in fear of talking about it are more likely to come to their doctors to talk about it now. The other thing is younger guys are experiencing erectile dysfunction for a number of reasons, porn being the big one. So you're seeing a lot of younger guys with psychogenic erectile dysfunction as early as their early 20s. And then you see guys in their 80s and 90s who have poor health and just, the chronic illnesses that essentially lead to erectile dysfunction. So you see men from all walks of life.
You just mentioned porn. So I mean, we can get into this later, but I was going to ask you about it anyway.
Yeah.
But are you saying that porn is leading to erectile dysfunction in this regard, or what do you mean?
Yeah. So definitely. I mean, I'll say this. So it's not just porn, but it's lifestyle as a whole for younger guys. So porn for one, and excessive drinking being the other one. But porn, I'll tell you, when it comes to porn, guys who porn these days, it's so vivid, right? So extreme compared to what it was when you had 56K and when you had magazines, right? So you're seeing these videos, these extreme videos, and it desensitizes guys.
Is that right?
Guys have this this expectation of what reality is going to be like, but it's never going to be compared to what is seen on these videos. So they start to experience their erections not as strong, they're not as satisfied, and they're having weaker erections as a result of it.
That is absolutely fascinating. Well, listen, what I want to do next is actually like, I think it's helpful to kind of go through, say, somebody coming to your office and doing a clinical workup type thing, because then we can kind of, kind of touch base on a lot of different elements that way. But let's go down this road first. Like, if somebody comes into your office, and let's just say it's, somebody in their early 40s, otherwise healthy, what are some of the questions you're gonna ask that person when they come in?
So as we talked about, is it difficult to get the erection or is it
Right.
difficult to maintain the erection being one? Their overall health, right? You want to know what their comorbidities are: diabetes, high blood pressure, high cholesterol levels, obesity. These types of things all contribute to erectile dysfunction. You want to know how their libido is. That gives you some sense of in terms of their hormone levels, because we know low testosterone could cause erectile dysfunction. And then porn, masturbation, how much they're
Yeah.
viewing that kind of stuff. Those are the big ones in terms of questions.
Right. How about in terms of your physical examination? What kinds of things are you looking at? I guess not only on the physical examination, but also on labs and ultrasound.
Yeah, so you definitely want to get a hormone panel, see their testosterone levels, see some of the hormones that are responsible for creating endogenous testosterone. You want to see their estrogen levels. And then also, in most cases, we get a penile ultrasound. And essentially what we do there is we induce an erection in the office. We check blood flow into the penis, blood flow out, and then we check the architecture of the penis. We look inside of it to see how the smooth muscle looks, any calcifications, any plaques.
That's it. Okay. So say you've gone through that workout, everything seems normal. Everything seems normal, at least in terms of the physical examination. There is, I understand a good component of this is psychological. What's the classic story of a psychological issue?
Yeah, so typically it's like you'll see let's say a guy in his 20s, right?
Yeah.
The story is he went out one night, had a heavy night of drinking, was unable to perform that night, right? Now, first time in his life he's been unable to perform, so he's going to remember that. Then the
Yeah.
next time he tries to engage in intercourse, things may start off okay, then he remembers the previous time. That little bit of stress decreases the amount of blood flow to your penis, you get erectile dysfunction again. So one leads to two, which ultimately leads to 20, and it becomes this vicious cycle. And that's the psychogenic version of it.
Right.
Yeah.
Right. And that, I guess the question is like, and I want to go down this way, probably finish that off before we get into the other parts, but what do you do about that?
Yeah. So, obviously you want to rule out the other things, right? Make sure their testosterone levels are okay. Health-wise, they're doing fine. Once you rule out everything else and you're really focused on the psychogenic, you basically try to snap them out of this cycle. So the way I do it is I start these guys on daily low-dose Cialis, as well as a supplement called L-citrulline. It's an amino acid that helps with vasodilation. The combination of these two essentially will help normalize their erections. You put them on this for a very short period of time, and what they do is, every time they want to have an erection, they'll have a very strong erection. That doubt, that frustration, that anxiety associated with erections should go away.
Yeah. L-citrulline, so it's an amino acid. So it's basically, is it just a nitrous oxide type
Precursor.
reaction?
Yeah, it's a
Is that
precursor
right?
of nitric oxide, exactly.
Okay.
Yeah.
Okay, so when you treat people like that and with otherwise no reason to think that they have anything physical wrong with them, what percentage of people do you think you're able to take care of at that point? Like, it's at that point, how many people are responding to that?
It's a good question. I'd say upwards of 98% of patients
Yeah.
respond well to that. That 2% who don't, I'll refer to them as sex therapist. Sex therapy
Yeah.
usually helps normalize the conversation around it, but yeah, it works pretty well.
What is sex therapy exactly?
So it depends. It depends in what situation. But like in this situation, if everything's okay, guys have anxiety and stress associated with sex, intercourse, everything leading up to intercourse. So similar to how someone when comes to social anxiety, you talk it through, you verbalize it, you normalize the conversation in your own head, and therefore you hope to decrease the anxiety and stress associated with it.
Yeah, yeah. Well, it's interesting. I guess that's another story entirely. I probably need to get a sex therapist on
Right,
here,
right, right, right.
try to spice it up. Okay. All right, let's go back to I mean, for the most part, the psychogenic stuff, it sounds like for the most part, if people have that, they have a very high percentage chance of just snapping out of it from what you said. And that vicious cycle that you said is like, I mean, that it seems like it shouldn't be that severe, but it's kind of a real deal. It's a real thing.
Oh yeah,
Yeah, yeah.
yeah.
Okay, so let's talk about the physical stuff here. When you, first of all, when you think about erectile dysfunction, sexual dysfunction in this way, do you think of it as something that's really related to age, comorbidities, and that kind of thing for the most part, or do you think of it as, independent of those types of things, or both, or what?
As a whole, I think there's, it's related to a number of things. There's four main causes to it. Blood flow being one, right? So when it comes to blood flow, you're thinking um, high blood pressure, high cholesterol, diabetes, the things that decrease the amount of blood flow to the penis. Medications as well fall into that category. Second thing is hormone levels. Testosterone being, the big one there impacts the amount of blood flow to your penis. Nerve function is the other one. So the connection between the brain and the penis is quite sensitive. So injuries to the pelvis, surgeries, spinal cord injuries could all cause problems with the erections, and then the psychogenic component, right? The one we were talking about. So all of those contribute to it, and at different guys at different ages, different elements will contribute to it. So as a guy ages, it's usually the blood flow and the testosterone levels that impact or lead to lower erections.
So I'm curious about on the hormone side. At what level do you see? I mean, like when we talk about testosterone, like this has been, something it seems like there's a lot of different opinions on this, but at what levels of testosterone do you think people are starting to see problems with libido and erectile dysfunction?
Yeah. So the numbers we say for testosterone, we say normal levels are anywhere from 300 to 1,000, right?
Right.
And it's quite subjective because it's not like at 290 you feel great, and at 350, or excuse me, at 290 you don't feel very good, but at 320 you feel great, right? So it's not so much you're treating the number, you're treating the symptoms. So to answer your question about libido, generally around 300 to 350, not for all men, but for most men, that's kind of the break point where if you're below that, you'll have low libido. If you're above that, your libido levels will be a little bit more normal.
Yeah. Your take, I mean, like, what's your take on different, some people talk about really optimizing testosterone in general, just for a variety of health reasons. And, I know you, and I think most of I would say the urology, uh, guard, so to speak, would stand by that. But there's this other movement just about in terms of trying to not only just look at symptoms, but say try to optimize people in those 700 ranges, that kind of thing, for other reasons, right? Like whether they be related to cardiovascular, brain health, things like that. What's your take on that?
So yeah, it's a really, I mean, this is a great question. So at the end of the day, you never really want to treat the number, right? You really want to treat the symptoms. So, but it's very rare to find somebody who is in the 200s and they feel great, right? Because if you really ask them, there's something off, right? Whether it's their energy levels, whether it's their libido, whether it's their sexual function. It's incredibly rare to find somebody who's literally in the 200s and is like, you know what? I'm on top of the world. Like, I feel great. Um, you just have to ask them a few more questions. They may not be interested in getting testosterone replacement. That's fine. But when you ask them the symptoms of low T, they have a few of them at least.
Yeah. And you know what? Other thing that I thought was really interesting as an aside was that the Framingham study, the cardiovascular study from the 1950s, that I think there was an average testosterone that was about 30% higher than it is today and these days. And first of all, do you buy those numbers, or do you think that's just lab error, or the way we used to measure things versus now, or whatever? And if it is real, why do you think that's happening?
I mean, so I don't know the answer as to if it's truly real. Maybe sampling.
Yeah.
But in fairness, I mean, in terms of what has changed, I think our lives have become a lot more sedentary, right? In the last 50 years. And we're not outside as much. We know with vitamin D, active lifestyles, moving around, these things are all important to testosterone or to normal hormone levels. So I would say potentially that could be a cause of why we're lower now than we were before.
All right, so let's say we've got now normal testosterone. Maybe we've got some comorbidities. So somebody may have a little bit of high blood pressure, maybe they're pre-diabetic or something like that. Um, what's the most common reason, like from a physiologic standpoint? If somebody has erectile dysfunction, what's the most common physical reason that they have erectile dysfunction?
So usually, right, the most common reason is something called venous leak. So to take a step back, you have to understand how normal erections work. So the idea is the penis itself has two balloons. Think of it, two balloons. These are the erectile bodies. Within those erectile bodies, there's an artery that runs through there, fills up these balloons, and then on the outside of the balloons there are these veins that drain the blood back to the heart. When you get enough inflow, it squeezes against those veins, therefore you get an erection. It keeps the blood within the penis, so blood's not exiting. Now what happens over time is those erectile bodies, the smooth muscle within them, they start to atrophy, or they're not getting as much blood flow, they start to get weaker, they're not engorging as much as they were before, therefore those veins on the outside are draining.
So the muscle, so that you're talking about, just maybe clarify that a little bit, where the muscles come in here, because
Yes.
that's important.
So the muscles are within the erectile, within those balloons, within the
Okay.
erectile body.
Okay.
We call them smooth muscles. Those are the ones that engorge with
Right.
blood. So those are the ones that essentially are responsible for strong erections. As I said, when you're not getting good blood flow into those areas over the course of decades, that smooth muscle, it loses its ability to expand what it did when you were 18. So those veins on the outside are able to drain easier, so you get blood
Yeah.
back to the heart. So it goes back to what I was saying earlier. You could get an erection, but you can't maintain the
Yeah.
erection. That's
Then
the
it seems
idea.
like that almost would be a vicious cycle, right? Like it would get worse and worse.
It gets worse and worse.
Yeah.
Yeah. And we don't have an answer for that. That's the problem.
The answer for
Venous leak.
for the venous leak. Well, okay, so that's probably a good time to move into what you can do about this. And let's start with, I mean, first of all, is there anything behavioral, non-medical that you can do about this? I mean, there's biohackers everywhere talking about stuff, and I'm just curious if is there anything in general that before you get to medicines that you would try?
I mean, so some people use cock rings, right?
Right. So that's a good point, because like people think of those types of things, those rings and stuff, as purely toys, but effectively what they're doing is kind of dealing with addressing that issue of leak, right? I mean, you're basically keeping your blood flow there so it's not leaking out. Isn't that effectively the same?
That's the only thing we actually have for venous leak. The only that addresses venous leak by itself.
Yeah,
That's
yeah.
the only real thing.
So it's not just a toy.
It's not, it is a toy, but
It is a toy.
It is a toy, but
it's
yeah.
not a toy. Okay,
Yeah,
well, that's good. Okay, so let's move on to meds. So before Viagra, there really wasn't anything.
There wasn't anything. Not anything good.
Tell us how the story of Viagra happened, because I think that's pretty amazing.
Yeah. So Viagra wasn't made for erectile dysfunction. It was initially made for sildenafil is the generic name for it, but it was made for pulmonary hypertension. So patients who had increased pulmonary artery pressures, this medication was made for them. And then what they realized is, I think there's two versions of the story. One of them is that guys who were taking it, none of them returned the medication, or none of them,
Yeah.
they're like, what the hell? And then the other story is basically when they surveyed the patients, the guys were like, wow, like my erections are have improved significantly while being on this.
Yeah.
So it serves two purposes. Definitely worked for the pulmonary hypertension. We use it for pulmonary hypertension at a lower dose, but it has the added benefit of erectile dysfunction and created this massive market.
Yeah, and they had, I think the story was in part also that they were also testing it for regular hypertension, and it didn't actually work. It didn't work for that. And I don't think that there was any indication at that point that it would have any effect on erections. But when they did the trial and they tried to get people to send back their medication, like nobody would send it back,
It's
which is great. What a great
the
story.
perfect side effect.
Right, then they come back and they basically decide they're going to survey. Well, why didn't you want to send it back? And it turns out, well, it seems to work great for something else, and so that's what happened. Well, that's interesting. That sort of has really sort of changed the entire complexion of this problem, right?
Completely.
Yeah. So, what are those medication options now? I mean, the broad category of these are called phosphodiesterase inhibitors. What do they do?
So the idea is, I mean, it's part of a cascade, but essentially what they do is they lead to vasodilation of that artery and the smooth muscle, as we were talking about earlier.
So they like open them up.
Open them up, allow more blood flow to go in, more blood flow, more engorgement. More engorgement means stronger erections. So that's the main idea. Initially, there was Viagra, then there was Cialis, then there was Levitra, Stendra. So now we have 4 within that category of these PD5 inhibitors, as we call them. All of them kind of have different pros and cons, but yeah, I mean, these are the mainstays right now for erectile dysfunction treatment.
What are the differences between them? I mean, because, I think there's all sorts of them on the market and people are probably wondering,
Yeah. So the 2 most common ones are Viagra and Cialis. So Viagra, it's the original one. So the Viagra basically kicks in within an hour. The key thing with Viagra, you have to take it on an empty stomach. I think a lot of patients forget this. Viagra has to be taken on an empty stomach. Like I said, kicks in within an hour. Cialis is the more longer acting one. It acts for as long as almost 36 hours. It's like the weekend one. No dietary limitations with this one. You probably have to take it about 4 hours before intercourse, 2 to 4 hours. And then also Cialis has the added benefit of it helps with BPH, enlarged prostate. It's FDA approved for that as well. So
Right.
Cialis is very commonly used because it has 2 indications. Then there's Stendra and Levitra. Stendra acts within 15 minutes. So that's a unique one. It's much quicker. So if you want quick action, Stendra. And then Levitra, it's kind of the in-between between Viagra and Cialis in terms of the timing of it.
Yeah.
So
how do you decide what to take? I mean, a lot of it is its side effect profile and that kind of thing, because I know there are, people get runny noses, people get, other issues, headaches. And is it just a matter of like playing with what works for a person?
yeah, it's like, I mean, the way to think about it is what fits your lifestyle or what fits that moment. So, um, so I would say mainstays really are, like I said, Viagra and Cialis. Those are the ones that we usually use. Cialis is really, really common because most older guys have erectile dysfunction. And like I said, it has the added benefit of the prostate BPH treatment. And then Viagra when they're looking for that extra boost before intercourse.
Yeah. So this brings me to like one of the most interesting things that I was kind of looking at when I was, reviewing some of the things that I want to talk about with you, and that is daily Cialis, which is low dose Cialis. What is that, like 5 milligrams?
5 milligrams.
5 milligrams of daily Cialis, and the role of it potentially as a preventative, because this is an interesting. What I had heard was that one approach would be to say, okay, you're getting a little bit older and maybe you notice things slowing down a little bit. Maybe you're starting to have problems. Not a bad reason to start daily Cialis at that point for a few reasons. One being, the potential benefit, and you can talk about like hypertrophy and all that of the muscles, but also just in general systemic health, cardiovascular health. So why don't you comment on it? Because I think this is just really, to me, this is like, well, why isn't every man over the age of 40 taking daily Cialis?
So I'm 100% with you on
Yeah.
that. I'm a big believer in this. So Cialis, so to your point, right? What it does is it lasts for 24 hours, right? 24 to 36 hours. It's very well tolerated at 5 milligrams. And what it does is it basically maintains good blood flow to your penis and systemically, but more so to your penis. And the thing that people forget is the penis really is one of those organs. If you don't use it, you lose it, right? So if you're not getting good blood flow to it, as we talked about, that smooth muscle, it atrophies over time, right? The smooth muscle within it, and therefore it leads to erectile dysfunction. Now, um, they've done studies, they've done rat studies. They've biopsied the penises of rats before and after taking daily Cialis or having Cialis in their water. And the smooth muscle has hypertrophy, like you said, after 90 days.
And basically, again, just not to use big words, but hypertrophy, meaning the muscles just got bigger, and that was one of the problems, and healthier, and that was one of the problems with the whole venous leak story, right? So now you're taking this daily medication, and not only are you able to get those erections more, fully, or more engorgement or whatever, stronger erections, but you're also in effect improving for the future. It's not just playing defense, it's actually going and actually repairing or improving the actual physiology that's the problem.
Yeah, at the very least, you're playing defense. But yeah,
Yeah.
you could, in some ways, maybe in a best case scenario, you could, add, reverse the aging of the penis.
Yeah. Well, I mean, if you're causing, improvement of the muscle, isn't that?
It is. But the only thing is, we've never been able to do a human study on this, right? No human's going to consent.
Yeah, right.
So we're translating the rat to. But I agree with you. Daily Cialis. I mean, even if you take it a couple times a week, it can only benefit you.
Well, and not just from the standpoint of sexual health, because this is what I think is really compelling. Because let's take a step back. One of the things that I also thought was really interesting when I was kind of getting ready for this interview was that the correlation between erectile dysfunction, that beginning of that, and cardiovascular disease. Do you want to talk a little bit about that? Because I think that is an incredible thing that no one talks about.
Yeah. So they say erectile dysfunction is kind of the canary in the coal mine,
right,
when it comes to cardiovascular disease. So as you can imagine, the arteries or the blood vessels to the penis are quite small. And if those are if you're getting buildup or you're getting decreased amount of blood flow to your penis because the arteries are thickening or the arteries are getting plaques, it could be a sign of what's to come in 5-10 years. And there's data now to prove this, right? We've done studies on this, where if you have erectile dysfunction, you're at increased risk of having some kind of cardiovascular event in the next 5 to 10 years. There's good data on this. So yeah, in many ways, it is the canary in the coal mine. But so therefore, I mean, that's why we always ask, if guys are coming in with erectile dysfunction, it's important to get them evaluated for everything else: diabetes, high blood pressure, high cholesterol.
So the reason I'm getting at that a little bit more is that, like, there's another potential win, although I doubt, you can correct me if I'm wrong, I don't think there's any studies showing anything long-term benefit cardiovascular-wise with daily Cialis. But, you can kind of look and you say, well, if daily Cialis is helping with blood flow to the penis, it's helping with the smooth muscle there. We also know that erectile dysfunction is a canary in the coal mine for heart disease, that potentially that the smooth muscle of the cardiovascular system, right, the heart, the blood vessels, may benefit from this as well.
To a lesser extent, but yeah. There's, some of my colleagues, the belief is now that there is some added benefit from a systemic standpoint, but definitely, from a sexual health standpoint, but systemically as well.
Yeah, that's again really interesting stuff to me.
The only other thing I would add there is, there's no. Before it was so expensive, but now Cialis is generic. Certain pharmacies you could get 90 pills for like maybe $10. Yeah, so it's dirt cheap now.
Yeah. Okay, so you're going to get people. What percentage of people in your practice do you think that's all they need? They just need, they need phosphodiesterase inhibitors. They're getting either daily Cialis or they're getting, the higher doses when they need them, that kind of thing. What percentage of people do you think that pretty much takes care of?
I'd say the oral meds about 2/3 of patients.
2/3 of patients.
2/3.
No, that's great. And just backing up, because I think this is a big deal, is that when we talk about how many people are struggling with this problem, we just said, 52% of people over 40. What percentage of those people do you think are even getting help? It's hard to measure what people aren't reporting.
Yeah,
right?
But I'd say a small subset of those patients. I'd say, I don't know, anywhere from about a third of patients probably are seeking help for
Yeah.
it. Yeah.
So now you're talking about, of those people getting help, the people who are not getting help, I mean, 2/3 of them you could just help with a pill. I mean, it's kind of crazy that this is such a problem that people don't get help for, but I guess it's, societal and shame and all that kind of quality of life stuff, right?
Right.
Yeah.
Right.
Yeah.
Right.
All right. So the 1/3 that's left now, what do you do there? I mean, do you get complete failures? And usually it's probably that maybe it helps a little bit, but they're still not getting enough benefit to actually have a normal sex life.
Exactly. So there's some level of improvement, but they're not where they want to be, right? So that other third. You want to talk about the other options. So the previous mainstays have always been intracavernosal injections, where you're injecting those erectile bodies, as I talked about, with these. Think of it like liquid Viagra, right? Different
Yeah.
chemical compounds that induce stronger. They're more concentrated, so you get more blood flow, more vasodilation, stronger.
How does that work? So literally right before sex, you're injecting yourself in the penis?
Yeah, you're injecting yourself with essentially like an insulin
That's
needle.
not a turn on at all, right? Like, well, it could be depending what you're into, right? But like needles into your own penis right before sex is probably challenging for many.
But once you break the taboo, it's not that bad.
Yeah.
A lot of patients are on it and they love it.
They do?
They love
Yeah.
it. I mean, I agree with you though. It's the idea of injecting yourself it's a tough pill to swallow. But once you do, basically the idea is you inject yourself at either 3 or 9 o'clock, right at the base of the penis. As I said, with various compounds, there's 3 different chemical compounds that could create this vasodilation. But ultimately, what it leads to, as I said, is a stronger erection. So that's intracavernosal injections. We offer that to patients as second line, or historically we always have. And then the third line, or the gold standard for erectile dysfunction, is the inflatable penile implant, right? And that's kind of the end of the road after you've discussed everything else with the patient.
How does that work? I know, like when you say it, you can kind of get an image of what that would be like you just like a football pumping up or something like that at this second, but like, how does it actually work? I mean,
So essentially, we replace. So as we mentioned, the 2 erectile bodies within the penis.
right.
We replace those erectile bodies with these cylinders, with these saline cylinders.
Uh-huh.
Those are attached to a pump that's in between the testicles, and then that is attached to a reservoir that sits in your lower abdomen. Everything is contained within the skin, or everything's within the body itself. It's all done through a small incision. Surgery probably takes about 45 minutes, depends who's doing it. But essentially, you're able to. There's 2 buttons on that pump. One that pumps it up, and then a release valve. So every time you want to have an erection, you squeeze the pump. The fluid from that reservoir goes into the cylinders, gives you a strong erection. No impact on sensation. No impact on it feels just as it did before.
Really?
But it's a hell of a lot stronger.
Wow. And then orgasm with that, it's normal.
Yeah, sometimes it's easier, right? Because when you have stronger erections, the threshold for orgasm is a lot lower when you have stronger erections.
Oh, is that right?
Yeah.
Interesting.
Yeah.
Okay. All right. Well, like, what do you think in terms of like when you resolve these? What percentage of your patients are medicine versus the the cavernosal injection, the injection you were talking about, and then the pump.
The pump. I'd say about of that third that's pump versus cavernosal injections, about 60% of them can stay on the injections, and then 40% of them go on to the pump.
Is that right? 40%.
Yeah, the pump. I mean, once guys, they hear about it, they talk. I mean, the thing is, a lot of these
They're
guys
talking to each other.
they talk to each other
Yeah.
about it. Yeah.
I mean, is that like is a pump? Is it like they just go into, they take a little break and they pump and it just come back? I mean, how does that work in practical terms? I'm just trying to understand logistically.
So the pumping process probably takes less than a minute.
Okay.
Right.
Yeah, yeah.
Some people do it. They don't want people to see it when they do it.
Yeah.
Other people are more comfortable. But
Right.
pump it up. Do the business, and then when you're done, you release it. There's a release valve.
Got it. Wow, that's interesting. You hear about a lot of other stuff too. Not necessarily for that level of problem, but in terms of some other things that are in the pipeline to help There's there's some stuff about shock waves, sound wave therapy. You want to talk a little bit about that? Because it sounds like that started out sort of as a thing that, maybe was hocus pocus, but now it seems like it's pretty real.
Yeah. Yeah, so there's a couple new ones within the shockwave being probably the best one out of this category. But shockwave therapy. So as urologists, we've historically used lithotripsy, high energy sound waves. We've used it for the last 30, 40 years, more
For
so
stones.
for kidney stones, right? For kidney stones. And the story is there was a urologist who went back and basically eventually had to take out a couple of these kidneys after numerous lithotripsies, and they saw that kidney for whatever reason was very well vascularized. The thought was why, right? Why is it that way? So after research, what we found is high energy sound waves. What it does is it creates micro trauma to whatever organ, and that micro trauma ultimately leads to neovascularization, new blood vessel growth. So what's an erection? It's blood, right?
Right.
So if you're able to get new blood vessel growth, you mean stronger erections. So shockwave therapy, the data on it's pretty good. If you asked me 3 years ago, anecdotally, I would have told you patients love it. But now we have data to support that it actually works well. Depends on which machine you use.
Okay, yeah, let's get into that because, like anything, this situation is kind of getting out of hand, right? There's like at-home things and all that. So why don't you dive into that a little bit?
So the technology, there's two forms of the technology. There's radial sound waves and then there's focused sound waves. Radial is just more diffused. Focused is like it sounds like it's more focused. So focused sound waves are the ones that actually work well, right? That's the one that penetrates deep into those erectile bodies, creating that microtrauma and the new blood vessel growth. The radial waves are what are a little bit more commercialized. These are the ones that you do at home. These are the ones that
Does that just mean it goes all the way around, radial, or
or
what?
it's more diffuse.
Diffuse.
It's just
Oh,
more
okay.
spread out.
Got it.
So as you can imagine, the more diffuse it is, it leads to you're not getting as much penetration, and the benefits aren't as apparent.
The at-home devices are typically radial. Are most of the ones in doctors' offices, are they mostly going to be um, sorry, the linear? No, no, no,
The
no.
focus,
The focus.
they should be, But one
All right.
question, whoever's interested is, that's the question to ask.
Mm-hmm.
That's the question to ask. Is this a focus machine or a radial machine?
I don't know if it's just because it's branding or what, but usually people, I always hear people talking about GAINSWave. Is that assume that's one of the focus ones or something like
Well,
that?
GAINSWave is kind of the company, right?
Yeah,
GAINSWave is the company that sells it, so
yeah.
it's a bigger but that the GAINSWave itself doesn't tell you whether it's
Oh, okay.
focused or
So they may have some other things going on, but okay, yeah. So focus, and so like, how does that work exactly? Somebody, and who is it for?
it's a good question. So it's really for it's for anybody, right? But we've noticed or we're noticing now that it's generally for guys who have mild to moderate erectile dysfunction, or at least that's who I would recommend it to. And mild, moderate, severe erectile dysfunction is all based on a questionnaire, a validated questionnaire. But if you're having severe erectile dysfunction, what kind of benefit you could get from a shockwave? You could get some benefit, right? But is it going to be to the point where you're going to be really happy without anything else? I don't know. But like I said, more so for guys who have mild to moderate erectile dysfunction, it could kind of push you over into that spot, that territory that makes you feel satisfied.
So in your experience, it seems to be helping a lot. I mean, obviously the studies are showing, but like, what are people saying in your office when you have, because you do this in your office?
Right, we do. Yeah, I mean, like guys like it.
Yeah.
Guys actually really like it. They'll come back in. So it's 6 treatments over 6 weeks, and then you come back in for maintenance doses. But yeah, with the focus machine that we use, guys are liking it.
Is this something that you would think of as potentially also part of that preventative regimen? Because you mentioned, we were talking about Cialis and daily Cialis, and this show that I'm doing here really is about longevity, lifespan, health span, and part of that, in my opinion, is like maintaining a long, healthy sex life, right? So if you think about this as, after 40 daily Cialis, and if you're would you potentially consider doing this for people who don't necessarily have a big problem right now, but just want to prevent things from happening.
Yeah, I mean, yeah, absolutely,
Yeah.
absolutely. I mean, there's no harm, right? I mean,
Right.
other than I mean, it costs money.
Yeah.
Um, but otherwise, it could only help, right? It could only help. It could only help with that in combination with Cialis. I would say are probably the best ways of preventative measures for
Right.
erectile dysfunction.
So I got to tell you, the one thing that I've been particularly sort of surprised about in our conversation is the popularity of the pump. Because on the surface, I mean, in just my own imagination on how that would work, it does not sound like a really appealing thing. But it sounds like, we were talking offline, this is something that's extremely popular now. And maybe talk a little bit about, the experiences that you've been hearing about, and then maybe some of the things that's coming down the pipeline to make this even more attractive.
Yeah. So, yeah, as I was mentioning to you, it's quite popular. It's more popular than you think. I know it doesn't sound to undergo surgery for erectile dysfunction sounds a bit extreme, but when the oral medications don't work, the idea of injecting yourself, as you can imagine, when you're traveling, carrying around this vial in order to inject yourself can be
Yeah.
quite uncomfortable. So, the penile implant's a great option for those guys, and I would tell you, truly, the guys are very, very satisfied with this. The recovery is about 3 weeks, 3 to 4 weeks. You're able to start having sex within about a month's time in most cases. Um, it's, as I said, sensation is exactly the same, if not better. Orgasm's the same, has no impact on any of that. It just gives you a super strong erection. Um, and then in terms of the advances, so one of the companies that we're working with, what they're doing is they're creating that pump, as I mentioned, that's going to go by the wayside, and essentially it's going to be Bluetooth. It's going to be a Bluetooth apparatus that's going to be able to control the amount of fluid that goes into those cylinders, and you're able to control your erections just from your phone.
So I'm going to be, let me ask you this question, because I know people at home are wondering, but do you get like porn stars and stuff coming in there for enhancements of certain things? Like what kind of things are people doing there just recreationally with this kind of stuff?
Well, I mean, recreationally, they're doing. I mean, I guess when it's their profession,
Yeah, I mean, it's the work, right?
it's their work. They have
Yeah.
that's what their job is. So,
Right.
they're doing anything and everything to get
Yeah.
these strong erections. So, for porn star, really, it varies from all. Some porn stars are just doing the oral medications, and some have the penile implant. Some of
Really?
these, oh yes, that's the other thing. Some of these, porn stars in their 40s, sometimes even their late 30s, they're getting these penile implants early on.
Right, because they may not even necessarily completely need them if they were normal, they were just everyday people. But I mean, if you've got a job you got to do it, right? So, okay. Oh, that's cool. All right. So we've talked about we've talked also about sound waves and shock waves. The other thing that's out there, there's two other things that I know of, I hear of. And let's start with the P shot. What is the P shot exactly, and is that different from PRP, stem cells, and all these other things that are out there?
Yeah, so the P shot, it refers to PRP, right? So
Okay.
platelet-rich plasma. So, urology, men's health, we're no different than these other fields of medicine who have been dabbling in PRP. I think ortho was maybe the first
Yeah.
one that popularized it. Kobe Bryant was getting it on his knees. So the way we use PRP is for, at least from a men's health standpoint, is we use it in the penis as well. The idea is that it could stimulate growth factor production within the penis. Growth factors lead to new blood vessel growth. Some other factors essentially go into the penis, giving you a stronger erection. So that's the P shot. The efficacy on that, we're still trying to figure that out. There's some new studies or new data that was published probably within the last 2 months in a small subset of guys. This was at the University of Miami, but basically it's equivalent, right? There's no real difference between placebo and PRP.
Okay.
So that's the PRP, and then there's stem cells, right? There's stem cells.
But that's separate from the P shot.
That's
That's separate.
That's separate.
With the P shot, so basically you're saying that there's really no clinical evidence that it's beneficial as of yet.
Well, that was one study. It was a small subset of guys. That was one study. Again, probably published in the last 2 months. I think it was July of 2023. Where there was no significant difference, at least in that validated questionnaire.
Yeah.
Anecdotally, however, this is the one
Yes.
that I would tell you that guys like it, right?
Yeah.
However, the caveat to all that is the placebo effect
Correct.
is,
Yeah.
is present everywhere.
Yeah.
So
And wasn't there also people looking at the combination of shock therapy and the P shot?
PRP, and that was that one was still, the data on that's supposed to be, we're still waiting for that.
Yeah.
We're still waiting for that.
Yeah, interesting. Okay, and then so by the way, with that, where do you inject that, and what's the idea with the P shot? Where is the injection?
Similar to the intracavernosal injections, right into the corpora.
Okay.
Yeah. So
Okay.
right into those erectile bodies.
Right into the, okay, got it. And then stem cells, same concept, except now you're using stem cells to do the same.
Yeah, you're using your own body stem cells.
Uh-huh.
That process is a little bit more intensive. So you have to spin it down. You take stem cells, typically from your fat cells, spin it down, get them down to essentially this stem cell concentrate, inject into the penis, and the hope is that it will lead to it will lay the foundation for more blood vessels, or at least to reverse the age of the corporal tissue.
So, I mean, that's when I know there's also been sort of, biohacker world, stem cells into the penis, and they're claiming huge benefits. But in reality, do we have any data there?
Not yet. The stem cell one's
Yeah.
not yet, right? And that's probably going to be a few years away on that. Stem cells there's a lot of FDA and there's much more regulation when it comes to stem cells. So the process of getting good data and good research on that's going to take a few years.
Well, I guess that's important to distinguish too, because you've got like a couple different pathways on stem cells. You could do, autologous stem cells, basically taking fat, spinning it down, taking your own fat, spinning it down, getting stem cells that way. Or you could go to like somewhere where it's legal, like Panama, and get, embryonic stem cells, right? So any difference, any thoughts on those kinds of interventions?
Yeah, so I mean the earlier the stem cell, like the embryonic ones,
Right.
the more potential they have. So I mean, I guess theoretically, those stem cells are probably going to have the most benefit. But again, you have to go elsewhere. You have to go to different countries. Some people feel uncomfortable doing that. But the autologous, those work in certain medical settings, and the hope is we could use those same things when it comes to erectile function.
Got it. Okay, so I think we kind of covered at least to a superficial level, I think people have a pretty good idea of erectile dysfunction in general, but I just wanted to talk about a few other things that are kind of related. Okay, I'm going to stop the show right there. As you know, I don't like to have these shows go too long. I want to make sure that you have just enough for your drive back and forth from work. So if you want to tune into the rest of the discussion, make sure to tune into the next show, and I'll see you then.